Over the half an hour or so, we're basically just going to go over brain tumor imaging, specifically focusing on MR perfusion and then MR diffusion, and how we can use that for evaluation of brain tumors. So we'll quickly review how we do MR perfusion, just a quick summary, and then we review the clinical applications in brain tumor imaging that can be used for tissue characterization and, more importantly, to differentiate post-treatment changes, including pseudoprogression and radiation necrosis from tumor recurrence. And then at the end of the talk, I'll talk about MR diffusion and some of the clinical applications for which you can actually use quantitative MR diffusion in brain tumor imaging. So this is our brain tumor protocol. Basically, we do a few of the conventional imaging sequences: T1, flare, gradient. Then dynamic contrast enhanced perfusion, DCE perfusion, is performed. And for this, we basically use it's a T1 gradient sequence, usually with a temporal resolution of 5 to 6 seconds, and it's about 5-minute scan. And then we do our T2 and diffusion, or some other things, specifically if they're referring physicians or surgeons they ask for. And then we end the study with DSC perfusion, dynamic susceptibility contrast perfusion. We split the contrast, that's 0.1 millimole per kilogram body weight to 2. Basically 40% of the contrast is used for the DCE component, and then the remainder of 60% of contrast is used for DSC perfusion. So two types of perfusion are done, and this table just going over the summary and differences between these two techniques. So DSC, that is more commonly used, I think, in most institutions for brain tumor imaging. Dynamic susceptibility contrast is essentially a T2 star-weighted technique. It's an EPI sequence, whether it can be gradient or spin echo. It basically measures a variety of things, but for the purpose of brain tumor imaging, the focus is really to measure vascular density, and that is calculated by relative cerebral blood volume. Advantage of DSC is that it's easy image acquisition. It's about 1.5 minute acquisition. It's broadly available, and post-processing is relatively easy. And again, there are even software packages free online that you can actually use to process this data set. The disadvantage is lack of absolute quantification. As you notice, we're talking about relative cerebral blood volume, so you always use the contralateral side to normalize the values. It is prone to susceptibility artifact. It is a T2 star-weighted technique. Therefore, it can be affected by, if you have blood products, for example, in your surgical bed, or if you're close to the airborne interfaces, it can cause artifact and distortion. DCE, on the other hand, it's a T1 weighted technique, and it basically, again, measures a variety of variables, but the one that we interested specifically for this talk is the K-trans. That is a measure of macrovascular permeability. It provides a different perspective of tumor angiogenesis. It looks at basically the macrovasculature, and it's not affected by susceptibility artifact because it's a T1 weighted technique, so that's the advantage. The disadvantage is relative complex pharmacokinetic model post-processing, but again, that has been, I think, addressed with most of the software packages that are available these days. So they are relatively seamless in terms of post-processing at this point.